Welcome back to another episode of the Braun Performance and Rehab Podcast, powered by ISOFIT and Firefly Recovery. ISOFIT is my go-to for all things isometric strength training. For more on ISOFIT, be sure to check out ISO. Episodes like this are made possible by Firefly, the official recovery provider of the Braun Performance and Rehab Podcast. For more on Firefly, be sure to check out recoveryfirefly.com. This episode is powered by Dr. Ray Gorman, founder of Engage Movement. Learn how to boost your income without relying on sessions. Get a free training on the blended practice model by following at Ray Gorman DPT on Instagram. Rachel, welcome to the podcast. I'm super excited to work with you today. Huge shout out to our mutual guy, John Gardner, absolute legend. Really appreciative of him getting us connected that way. For people who aren't as familiar with you as John and I might be that way, would you mind filling them in a little bit about who you are and all the great stuff you're doing down in the Charlotte area?
For sure. Thank you for having me. My name is Rachel. I am a physical therapist. I'm a strength and conditioning specialist through the NSCA, and then I also have my CPSS, so Performance and Sports Scientist certification through the NSCA as well. I own Synthesis Performance and Recovery, which is a kind of collective wellness space in Charlotte. So we have a kind of gym and office facility, but we house physical therapy, chiropractic, nutrition, mental health, and personal training. So we all work under the same roof. But I own that, which has been a really fun project. I've worked anything from, insurance as a staff PT, moved up to clinic director, moved up to partial owner, moved up to full owner, subleasing, and then now full owner and actually having my own space. So that's been an interesting journey. But I specialize in pelvic health, and I'm TBI certified. So lots of golfers.
Yeah, and one of the things, as you're telling about yourself, obviously, I get this sense of some kind of athletic background. CSCS, CPSS, TPI, like those are all very athlete-minded type of certifications that way. So I'm assuming you're somewhat of an athlete yourself. I think the endurance space, is that correct?
I grew up playing soccer, and funnily enough, you grow up playing soccer and you're told to run all the time. So when I was playing soccer, I would have said that I hated running. You finished in college, and so moved on, and you kind of have this almost resentful nature, I think, towards running, where it's kind of like, I'm not doing that for, as long as I possibly can, because you've been, told for so long to do it. So it took like probably 6 months to a year off of any type of training, whether it was strength training, running, etc. And then you start to realize that, like, I don't feel very good, right? Like, that actually did make me feel good to do those things. And so continued just doing strength training. More recently got into running, but over the past 5 to 7 years, that kind of coincided with me having kids, because that's my space to, get out of the house and no one needs me and I'm not staring at a screen for a little bit. So that's my opportunity to, work on my own personal goals. So running has kind of developed from that. So a mix of strength training and running, but I'm not going to sit here and say like a hybrid athlete per se. I feel like that's all a trendy thing right now, but purely strength training for several years, and then had kids, and then now lots of running with some strength training involved.
And it's so interesting because you mentioned the word running, and I just think back to the college side of things for me when I was in college. And one of the things that really opened my eyes was becoming friends with some of the different people in the running space, cross country, track and field, and so on that way. And through conversations and stuff, some different things came up that I was very much not prepared for in my early 20s. Things like, yeah, well, when I'm running, I usually like pee myself. And I was like, oh, that's new. Like, I didn't know that was a thing that happened. And they're like, oh yeah, we all do it. Or, oh yeah, it happens all the time. Like, we all have an extra pair of shorts on meet day because we're going to pee ourselves when we're running. And I was like, wait a second, is this like a common thing? And it turns out that the pelvic floor in athletes is actually really freaking important. And that's something, at least speaking for myself and maybe a few other male PTs, when we were going through PT school and we select our con eds and certifications and stuff, I'll be honest, pelvic health was not necessarily towards the top of my list. But now I'm starting to look back and realize, like, oh shoot, this is actually a lot more important than maybe I thought it was that way. So from your own kind of mindset and framework that way, with your own expertise and experience blending pelvic floor with more of a performance-minded rehab model, if you will, where the heck should rehab providers start in tackling the pelvic floor with the athletes that they get to work with day in and day out?
Yeah, that's a great question. I think it's so easy, in our profession. It's improving, don't get me wrong, but I think in our profession, just from the schooling that we went through, like I think we got a 1 hour lecture on pelvic health, and it wasn't anything crazy. It was very much just like, hey, this exists, and that's that. The reality is the pelvic health and running discussion, there was no discussion about it until 2019 was the first published paper about running and pelvic health. So 2019, the very first one, and that wasn't even like peer reviewed. That was just like some people getting together and being like, hey, like this is what we think because like, there's nothing out there. So I hate that our profession treats it like this gap of like, okay, you either do pelvic health or you do orthopedics. And I see it all the time. People end up in my clinic who have done both, right? Like I went to, let's say I have low back pain. That low back pain, I went to an orthopedic PT. It didn't get better. Okay. And then I went to a pelvic PT and I saw some improvement, but I still can't run, jump, deadlift, all those things. The pelvic health muscle or pelvic floor muscles, they're just muscles, right? Like we know anatomy, physiology, we know strength training principles, we know neuromuscular education, we know how those things work in every other muscle in the body. And for some reason with pelvic health, we just pretend like it's a totally different ballgame, right? Because I can't see the muscles, we're just going to call it a day. But the reality is, if you're male, you've got 9 to 11, depending on if you count piriformis and the pelvic wall. Or if you're female, you've got 11 to 13 different muscles down there. So I tell people all the time, pick 13 other muscles throughout your body, your quads, your calves, any muscles in the hand or the forearm, and just pretend that you don't know anything about them, how they work, how to move them. You would have some deficits associated with that. The good news for most of us is that we don't really think about pelvic health until it becomes a problem. So a lot of us, again, before we notice issues, the pelvic floor works very subconsciously. We don't think much about it. But if it takes enough of a beating, and it takes enough like endurance, and it takes enough power and strength or hurdles or things like that, eventually it can start to bother you. And then when it starts to bother you, then you get stuck in this weird systemic like, oh, do I need to go to a urologist or is it a gynecologist? And it's very rare that you actually end up in a pelvic PT situation. Most of the people that come to me, I'm like last resort, right? Like I've treated triathletes who have like a pudendal neuralgia where they've had like tailbone pain and hip pain, and it's been treated as like proctalgia or prostatitis or any of those types of things that don't have anything to do with actual muscles. We've been blaming the bladder, we've been blaming the prostate, and not understanding that, again, those muscles are down there and they affect everything around the hips and the core and all of that, everything up and down the chain. But we don't get that education, and neither do a lot of the medical providers, right? So a lot of times you go in and you say to your medical provider, hey, I'm having leaking when I'm running. And one, people are embarrassed to talk about it because it's just not a super fun thing to talk about. Or two, they have talked about it and they've been told like you said, like, hey, yeah, we all do this, right? Every time that we start to get tired or you hit the last couple hurdles and that's where it really starts to happen, then you just accept that, hey, this is part of the sport, and it's not. But the awareness of it has not been enough for people to understand what to do about it.
Absolutely. And it's one of those things that I think, in my opinion, it is the missing piece in a lot of the different things that keep popping up in the clinic settings, right? I'm pretty sure everyone has worked with an athlete with lower back pain or hip issues and so on that way. And we'll assess things, right? We assess the range of motion, the strength, and so on that way. We just try and blame what we see. However, we don't think to look at areas that we might not normally see when people walk into our clinic under normal circumstances that way. Obviously, there can be some comfort levels associated with that. And there's also some knowledge gaps as well, right? Like I would not pick myself to be the best person in the world to do some kind of pelvic floor assessment of any kind because I don't know where to begin. But the other piece I would say with that is it doesn't have to be all internal in nature. There's still a lot of assessment that can be done through the power of asking questions, having honest conversations, and even just external type of things that way. So from your eyes, if you're going to start assessing someone for some kind of pelvic floor dysfunction or anything, whether that be hypertonicity or whatever that way, how do you kind of go about things from a non-internal standpoint to the pelvic floor?
You can totally do an external pelvic floor assessment. Now, is it going to give you as much information as a vaginal or rectal exam? No, probably not. But you can get a lot of information from an external assessment, right? So finding those sits bones going slightly medial to them. The comfort level of that is what I think a lot of us have to work on, because if you feel uncomfortable, your client is going to feel uncomfortable. Like, there's no doubt about it. And if you're hesitant to say and you're not confident when you get up there and you say, hey, listen, like, I'm going to be near that kind of like sensitive. If you sound at all hesitant, your client's going to be like, no, thank you. Okay. But if you can explain, hey, like, this is the pelvic floor, this is what it does, this is why I think that it could be related to what you have going on. You've got 3 different muscles that attach to your tailbone. You've had this chronic tailbone pain. It hasn't responded with time. What could we do a little bit differently? And you can go into it with that confidence and awareness. Then your client's going to feel a little bit more comfortable with you doing an external assessment. So external assessment is totally an option. I truly believe that every single PT, no matter if they're qualified in pelvic floor or not, should be aware of how to do an external pelvic floor assessment. And then let's say, like, okay, Dan, you don't want to be a quote pelvic floor PT, but you've got this patient who comes in with chronic low back pain, hip pain. You do an external pelvic floor assessment and you say, hey, something's not right. Like, I can't feel that contraction. I can't feel relaxation. You don't have great control here. Okay, let me refer you to a pelvic PT so that they can take it from there, right? The same way when someone comes in with a situation with their hand, let's be honest, like, we have certified hand therapists. Like, something basic, sure, I'll help you. But if it's something really nitty gritty, I would rather you go to the person who I really think can handle this in the best way. But we're all, as PTs, trained to look at the hand and assess the hand and come up with a game plan until we get them to the correct provider. Pelvic core should be the same. So external assessment is totally an option. And again, when you explain it to clients, usually they're like, oh, well, yeah, that makes sense. You don't go to the OBGYN not expecting that they're going to do some type of pelvic exam. And you shouldn't really go to a PT thinking I need some help with some pain around my pelvis, not expecting to be touched around the pelvis. Now, that said, clients have full autonomy, right? So I have clients all the time who I say, listen, I can get way more information with an internal exam, but they may not be comfortable with that. That's fine. We don't have to do internal. And again, I think this is where we start to delineate a little bit, like pelvic versus ortho. And for most people, that feels like, do I do internal exam or not? I have so many clients, even in telehealth situations, where I can't do an internal exam for obvious reasons, who we can change their symptoms based on their subjective report. What do you feel, right? If you sit on your hand, do you feel movement of your muscle? Can I cue them on a Kegel or a reverse Kegel? Do they understand what that actually means and what they should be feeling? And if not, can I teach them that? And none of that, even, I don't have to touch them for any of that, right? So not only do I not have to do an internal exam, I could do an external exam, but I don't have to do that either. If they tell me, like, subjectively, my symptoms fall into this category, all right, I'm going to think like, all right, we're thinking pelvic floor overactivity. Okay, that's where we're leaning. Or pelvic floor underactivity. Now, can you self-assess? Can you do these things? And can you tell me what you feel when you do them? Or if you feel anything at all? Do you feel pain when you do a Kegel, right? Do you feel pain when you jump that hurdle? Is it when you land? Is it when you leave the ground? Where do you feel pain? Where do you feel like you have leaking? That subjective report can give us plenty of information that we don't have to do internal, and in a lot of cases don't even have to touch around the pelvis. That said, most people come to PT knowing I'm probably going to be touched around the pelvis. It's just important that you communicate to them what you're doing, why you're doing it, and what information you're trying to get from it. And then obviously documenting that consent.
Absolutely. When you explain it like that, it's no different than when I do spine manipulation on someone.
Exactly.
Right?
Exactly.
Where my hand is going, what we're going to be doing, why we're going to be doing it. We document the consent that was given and so on. That way, it's the same concept. It's just a slightly different region. And as you were talking, you mentioned the Kegels and reverse Kegels multiple times that way. And that always comes up when I'm talking with people about the pelvic floor. And I had someone be like, yeah, I do pelvic floor therapy, Kegels, 3 sets of 10. I'm like, I think there's more to it than that. Now, obviously, it sounds like it plays a really essential role in the assessment process, but from an intervention standpoint, there's a heck of a lot more to this than just doing a few Kegels every now and then.
And that's exactly kind of what you were saying earlier, is there's this big gap between what pelvic health is from a Kegel or reverse Kegel on the table in the treatment room to, hey, I want to qualify for the Boston Marathon, and every time I run downhill, I have leaking, right? Like there's a huge gap between those two things. And for so long, pelvic health has not helped itself by putting itself in this box of that is all we do. We just do pelvic floor. We just do Kegel, reverse Kegels. Versus, can I take all those muscles that don't actually in real life work in isolation, and can I put them into a situation where they have to work with everything else? So when you do like EMG studies of the pelvic floor, there's more pelvic floor activation in a lunge than there is in a Kegel, right? So clients come in and they say, hey, when I'm done, like when we fix these problems, when I discharge, do I have to keep doing these exercises for the rest of my life? You don't need to keep doing Kegels and reverse Kegels. You should be able to do those when you do your lunges, squats. Now, at first, that's going to feel very conscious, but I want it to go back to how when you did all that stuff before you started having this problem, you never thought about the pelvic floor. I want it to be subconscious, but for us to get there, we may have to do some conscious effort first and figure out what the heck we're trying to do. The same way when you come in after, an ACL repair and your quad won't turn on. All right, cool. Like, let's start with the basic. Let's start with the quad squeeze. Let's see what that feels like. Let's communicate on that. And then when you finish rehab, you don't have to go home and do quad squeezes for the rest of your life because your quad works day to day. So the goal is when you finish, you're done. You don't have to keep doing Kegels and reverse Kegels. Is it something important from the very start? Sure. But again, we're missing that. If I discharge you after, cool, you can do Kegels, reverse Kegels, you may be able to sit at a desk without pain, but you may not be able to run and jump and laugh and do all the things that you really want to do. And that's, I think, the bridge that we need to close between pelvic health and orthopedic health, right? That they should be the same. We all should be educated in pelvic health, and all pelvic health therapists should also be well educated in sport performance and orthopedics, at least at the level of I need to know when I need to refer out.
Absolutely agree with that. It's so interesting to bring that up as well, because one of the things I mentioned on a podcast we recorded earlier today was I love when patients ask me questions as a provider. And one of the things, if I'm a patient, I'd think to ask my rehab provider is, when do I stop doing this, right? When do I actually stop stretching my hamstrings? When do I actually stop doing this core activation? What does that end goal look like? And in nature of the pelvic floor that way, knowing that the end goal is not Kegels for life, it's actually just daily function, right? Your normal workouts, your normal day-to-day things, and hopefully you don't even need to think about whatever the heck a Kegel is after we wrap this whole process up. Like, that's nice to know what that end goal is. And I think once you begin with the end in mind, you're able to reverse engineer a plan from there. You mentioned that the lunge tends to be a higher EMG activation of the pelvic floor. What other closed chain or typical like performance-ish exercises show good pelvic floor activation? What does kind of that progression look like from your mind as far as where I might introduce someone to pelvic floor interventions after the initial Kegels, biofeedback, that sort of thing? And what does that end stage look like, right? Like, obviously, I'd imagine if you take that lunge and you throw more load on it, you're probably going to get more activation. But are there other variables that we can introduce that add even more activation of that tissue?
Yeah. So usually when I'm looking at a plan of care with a client, let's say that they come in and they've got pelvic floor overactivity or underactivity, both could apply here. Usually I'm telling people we're going to split this up into about 4 phases. Okay. So phase 1 is, to me, I tell patients it's like brain games. It's a lot of thinking. Okay. It's a lot of sitting here. Do I feel a Kegel? Do I feel a reverse Kegel? What does that mean? How does that coordinate with my breath? Because the diaphragm and the pelvic floor move together. So if I have a client who can't move their pelvic floor, how can I help them move their diaphragm to kind of get that moving in the correct direction? Okay. So phase 1, brain games. So let's say we've got a 12-visit plan of care. We're going to do first about 3 visits is going to be brain games. All right. We're going to get the pelvic floor online. We're going to get the core online, and we're going to talk about how those two things work together. But it's very basic. It's very thought provoking. It's very much like no extra weight. All right. Then phase 2, a little more functional. So take that pelvic floor movement that you have now. Can you use it when you get out of bed in the morning. Okay. So when I wake up with a full bladder, can I get to the bathroom without problems? Right. So functional movement. Now, if I like take all of these things that we just worked on in the brain games phase, can I do a just body weight sit to stand? And can I use my pelvic floor when I do that? If I twist and rotate, take like a Pallof press, for example, like if I rotate, where does my pelvic floor turn on and off? And be very conscious of that. Can I take that and make it functional? Then phase 3, so those next 3 visits, strength. Let's add some weight. So don't add speed yet, just strength. So can I take those lunges? Can I take the sit to stand? Can I take the Pallof press? Can I do all those things with weight? Or does my pelvic floor start to go offline when I start to add weight? Because sometimes body weight feels great, but then when I do my deadlift with weight, then my back starts hurting or then my tailbone starts hurting, okay? So adding weight and coordinating what's supposed to be happening at the pelvic floor during that, then power. So then the jumping, right? So jumping, quick, explosive movements. For a lot of my clients, teaching them that exhale, the reason we do the exhale at the hardest part of that movement is because if we put that pressure out of the mouth, it doesn't go down through the pelvic floor. So like, for example, the runners who have, let's say that I always bring up hurdlers because they just have that like, landing on the other side. Can you think about exhaling when you land? When you come into contact with the ground, can you do a quick exhale? That exhale is also going to promote a Kegel. So the Kegel promotes closing. So if you have a full bladder sitting on top of those muscles, the exhale means pressure goes out the mouth and we close, right? So now we can create what we've been trying to create, which should be subconscious, but it's not at first. And then eventually enough practice, it becomes subconscious and I don't have to have my exhale to make it happen. It just happens on its own. The body knows we're about to hit that impact point. So usually like 25% kind of brain games, neuromuscular re-ed, 25% functional, 25% strength, 25% power. Now that depends. Sometimes people come in and they've done all the other stuff with a different PT, but still haven't seen the results they want. Maybe we pick right up at strength and power. Maybe you don't need the control stuff. You've already done that, or you did an online program and that all feels great, but it's not translating. All right. In those cases, you asked about like the exercises that I feel like kind of overflow the most with the pelvic floor: lunges, squats, deadlifts. Yesterday, I had a client, we did some really high step ups. She's an aerial athlete, so she does a lot of like upside down spinning and open leg positions, right? Where we don't have support from the adductors. So one leg's here, one leg's here. We have to have a really strong pelvic floor to do that and not feel your back or your hip hurting you. So now can we train the pelvic floor in stretched positions? So if I do a staggered deadlift, can I add an internal rotation component? Now my pelvic floor is stretched on that side. Now can I Kegel as I come up and exhale and explode, right? So yes, it's a staggered deadlift with internal rotation, which we use for hip back pain all the time. But can I just put like a little twist on it to make it pelvic floor and make it functional for what she's actually trying to do? That's what
It sounds like going back to understanding the anatomy and the muscular function, and then being able to apply that to compound movement patterns and just make small adjustments to the ones you're already using to make it a little bit more pelvic floor minded, if you will. Quick break, because if you're a rehab professional sick of burnout, this could be your answer. Engaged Movement's blended practice model is a proven system built by Dr. Ray Gorman, a PT who walked away from the 55-hour-a-week grind and built a blended practice model that doubled his income while working less than 25 hours a week, and he didn't have to rely on the traditional way of selling sessions to do so. It's all about blending remote and in-person services, stacking monthly recurring revenue, and building a business that finally supports your life, not the other way around. This model isn't just theory. Real providers, including myself, are creating lives of freedom and flexibility without being tied to their schedule. And as a listener, you get free access to the complete training. DM my name, Dan, to @RayGormanDPT on Instagram and receive your free breakdown on the model.
Correct. And some of that is just awareness, like where do I need to do the Kegel and where is the reverse Kegel? And at first that can feel really overwhelming for patients. Like I have some clients in the first couple of visits who are like, this is just a lot to think about. I tell people all the time, like, again, my goal is not that you have to think about it forever, but you do need to know how it works so that you can connect to it and then make it a subconscious habit. And sometimes you'll discharge and you feel great, but then you up your training intensity and notice, oh gosh, my symptoms are coming back. Well, then can we reset, right? You know what works and you know why it works. So can we reset and tweak it a little bit so that you only need to come back if you really need me, right? My goal as a PT and as a coach is that you don't actually need me. That means I did a good job. So when clients reach out and they're like, hey, I haven't seen you in a while, but it's because I've been doing well, it shows me you understood this is how the pelvic floor works. So just because I changed my training, or just because I wanted to do a trail run instead of a road run, or just because I did a race that had a lot of downhill versus a lot of uphill, I understood what we worked on. And so I just tweaked what I did too. That means I did a good job, as much as it sucks for business, right? Like, sure, I want you in here, quote, 3 times a week for 12 weeks, but that's not how a good PT should function. My goal is to get you out of here.
Absolutely. And obviously, I think one of the biggest issues I've seen with our current medical model is the reactive element to it, right? You mentioned it earlier. A lot of people don't even know what the pelvic floor is until they have issues with it. So is there anything we could or should be doing from a preventative side to possibly prevent these issues from occurring in the first place, right? Like you mentioned that RDL variation a little bit ago and adding the hip internal rotation, right? Is that something that provides value from incorporating into a strength and conditioning program for a little bit more of like a pelvic floor prevention, if you will? Or is there anything else that we should be looking to include to be a little bit more proactive on this?
I think if you're working, in a sport environment with a team, we're talking like, let's talk about teams, and women and men who obviously don't have kids, haven't been through childbirth. Because adding childbirth, adds a whole nother layer to it. It's going to make you more vulnerable to these situations. That said, let's talk about like high school, college athletes who are just trying to be, like you said, preventative. Do they know what neutral core is, right? Can we get all these athletes in one room with a pelvic health PT or a PT who understands this and have that PT teach them neutral core? Because we say it all the time, right? Neutral core, neutral spine, all that kind of stuff. But when you watch people actually do neutral core, they have no freaking idea what they're doing, right? So not only now is my core, most of the time clients do what we call ab gripping. So they like lock down the top of their rib cage and their lower abdomen will push out. And when that lower abdomen pushes out, the pelvic floor is also going to push down. So I tell clients it's like a tube of toothpaste, and I squeeze the top of it, and the bottom, we're seeing some of that pressing and that extra pressure that we really don't need. Where a true neutral core is going to come with the rib cage down, the belly button down, the hip bones almost draw together a little bit, and the pelvic floor lifts, so it wraps and lifts. So a true neutral spine has a little bit of a Kegel to it. But if you don't know what a Kegel is, no one's ever talked to you about that before, or just like being in an environment where like Kegel is a like hilarious word and everyone like can't wrap their minds around that, speaking to, a high school boys program. The reality is like a neutral spine has a Kegel. So if you like don't know what that is and don't know what that feels like, and now we're doing really aggressive core work, right? Let's say we're doing the leg lowering where your partner like pushes your legs down and you have to catch your legs and pull them back up. Can I do a Kegel with that, right? Can I get a neutral spine with that? And do I actually know what that looks like? And in those athlete environments, when you have all your athletes in one room at one time, can you just take an hour? Everyone lay on the floor. Let's talk about neutral spine. Put your hands on your belly. What do you feel? Does your belly move up or does it move down? Do you feel a Kegel? Do you know what that feels like? Here's my cues for that. Here's what you should be feeling. And if you leave this hour and you're like, I have no clue what we just did, that's a risk factor, right? That's, hey, let's get you connected with somebody who can tell you these things. And again, we're talking pre-symptoms, 30 minutes with a PT. Let me just show you what I'm talking about, right? Let me just give you some cues. And then that way, the next time that you guys show up and you're doing your 10-minute core burnout at the end of your workout, you know what that feels like. And then that way, hopefully we prevent it before it becomes a problem.
Absolutely. And a lot of the time, it sounds like it's getting people in tune with what's existing in their own body, right? It's like, oh, yeah, it doesn't really come with an owner's manual. It's like, how does this work? You have to almost teach people how to navigate their own body and how to use their own muscular system for, really their first time consciously, I'll say. Now, obviously, as we talk about athletes, we've talked at length, I would say, about the endurance component, but what other athlete populations do you typically see pelvic floor dysfunctions in? And does it tend to be more along the hypertonicity or hypotonicity side, or does it have more of a neural component? Does it vary based on sport that way, or what's kind of the overall breakdown for you as far as incidents based on activity that way?
Highest incidence in terms of pelvic floor dysfunction, especially from a like leaking perspective, is definitely track, gymnastics, and any type of sport where we have to hold a posture for a long period of time. So think like figure skating, like ballerinas, dance, gymnastics, where we're really like tight and core is tight all the time, right? No one is meant to be in those positions for totally extended periods of time. Sure, for your routine, we need tons of core activation, right? We need tons of neutral spine and all that. And that does involve the pelvic floor. But does your pelvic floor actually relax when your routine is over? And if the answer is no, then we're going to see problems associated with that. So I tell clients, it's like if I walk around with my hand in a fist all day long, right? So I'm here, you ask me to perform, I'm here, I'm tight, I'm squeezing. And then finally a pelvic PT is like, wait, you got to relax. And I finally pry my fingers open. And then if I tested my grip strength, it would be awful, right? Because my muscles are just exhausted by that point. But the reality is a lot of our athletes, and especially, again, a lot of these postural athletes, what we're looking at is that at the end of the day, when they lay down to go to bed, those muscles are still tight because that's what they do for sport, right? And unless they take that conscious time at the end of a routine or the end of a practice, just 5 minutes of what we call down training, right? Nice deep inhale, expand, push the pelvic floor away from your head, forcefully get it out of a Kegel, not bearing down, but stretching, getting it out of that Kegel position to let it relax. That's where, again, we start to see problems. It's usually hypertonicity. So it's usually overactivity. Pelvic world's trying to shift away from hypertonicity since hypertonicity is technically like a central nervous system problem. So they're kind of saying more like overactivity, but you'll see a lot of overlap depending on who you're talking to and how long they've been doing pelvic floor work. So we tend to say like pelvic floor overactivity is what I'm going to see mostly in the athletes that I work with. The other thing that we tend to see is any rotational sport. So when you're talking about like tennis, baseball, golf, that's a huge pelvic floor component because it's also a huge oblique component, right? So it's a hugely emphasized core sport. You have to be able to create power, pressure at the core to translate that power from your lower to your upper body so that you can hit the ball and create that same consistent force every single time. And if you don't have hip rotation or you don't have control over that, that is going to place extra demand in places that it shouldn't. So again, a lot of the golfers that I work with, and a lot of them are male, they come in and they have no idea about the pelvic floor. And honestly, until I sit there and we have this type of discussion, they're like, I don't want to talk about that. Like, what are you talking about? But if I ask them about, can you do this? Can you do that? They're like, oh, wait, I've never tried that before. And it does, again, it doesn't always have to be like we're going to sit here and talk about a Kegel and reverse Kegel. Maybe I start by working on your active hip internal rotation because I know that will stretch your pelvic wall, which attaches to your pelvic floor, right? Like we can kind of nuance our way around it until they're ready to get to that. But the rotational athletes have to have that control. And if they don't, it usually, what I see clinically is back pain. So back pain with swinging, right? Back pain with swinging the golf club, swinging the bat. The challenge with golf and baseball is that you're always swinging the same way, right? So it's just the same movement over and over. At least with tennis, there's some forehand and backhand. So there's a little bit of side to side. But golf, baseball, you're always swinging the same way. You're always throwing the same way. And a lot of times for them, they feel like when they can get their pelvic floor online, that power is more consistent. It doesn't feel as hard to throw at the same speed or to hit the same distance. The effort is less. It's more natural and subconscious.
I think you've just had every athlete ever in golf and baseball buy in by saying, hey, you're going to get more power, you're going to get better exit velocity, all that sort of thing. It's amazing the impact that can come from correcting some of these underlying issues that way, because as you mentioned, it's very regional interdependent, if you will. None of the systems in the body work independently. They all need and rely on one another that way. So, we might think, oh, well, it's just this one muscle at the hip and we've just got to blow that up. That's a very small way to think, when in reality, it's a lot of other pieces of the puzzle coming together that ultimately play into that performance factor. And I know you mentioned trying to get away from the word hypertonicity and getting into more of a overactivity model, if you will. One of my favorite things to do when I have athletes come in with something overactive, especially if it's like an upper trap or something like that, is I stick a needle in it. And let me tell you what, they leave feeling a lot better. Maybe a little sore. Maybe they feel like they got a little beat up. But in general, it's like, wow, that thing can actually relax now. This is what it's supposed to feel like. And I've had some conversations with people lately around dry needling. And some people have brought up the concept of dry needling for the pelvic floor. And naturally, when I think about it at first without kind of getting into it too much. I'm like, wait, needles down there? That doesn't sound enjoyable and therapeutic. But after we kind of peel back the layers, it's like, oh, actually, that does make sense. So I'm curious, do you ever needle someone for pelvic floor dysfunction? And if so, what does that kind of process look like for you?
For sure. Lots of education, right? So again, you have to be able to talk to your client in a way that's comfortable. And again, I always try to go back to the idea that like I don't go to my gynecologist and expect them not to talk about my pelvis, right? If I'm with a healthcare professional and we're doing a good job, then when my client trusts me, and if they don't trust me yet, maybe we wait. Maybe we defer that conversation for a couple of sessions until I feel like we're on the same page. So that's definitely step one. Step two is a lot of times we can just do the quote regular dry needling. Like maybe we start with the piriformis, or maybe we start with like the glutes, or maybe we start with some of the deep hip rotators. And then they start to notice, wow, that does feel so much better, right? The adductors play a huge role with the pelvic floor. So sometimes we'll needle adductors, like start there. And then you can kind of work your way up if you choose, right? But a lot of times what I have found is when we needle some of the like global stuff around the pelvic floor, as long as we're also working on the awareness and isolation of the pelvic floor, we don't have to always necessarily needle the pelvic floor directly. And that, again, my population is biased because it's not like what I would say is like the quote classic pelvic health, group of individuals. It is very active, very, athlete, whether it's recreational or elite, like they're trying to use all these other global muscles too. So it's not, a client who is just saying like, hey, I have a problem, like just sitting at my desk. Now I treat that too, but a lot of my clients are like in that global athletic kind of sphere. And so a lot of times for me, needling some of the quote normal stuff and teaching them the control piece means that the nervous system can kind of all latch on at once, right? So I just needled your piriformis, your deep hip rotators, and your adductors, and then now you're going home understanding what it feels like to actually do a diaphragmatic breath, do a reverse Kegel, and all of that can kind of work together to overflow. So if pelvic floor dry needling just feels super overwhelming and doesn't feel like something your client's going to latch on to, it's not a have to have, right? And you can do, depending again on the client, you can do internal work, vaginal work, rectal work. We have the pelvic wand, which I tell clients is like a foam roller for the pelvis, right? You just can't get to those muscles in an external way with foam roller. So the pelvic wand, I have a lot of my runners like hold on to that. And listen, if you have a like really heavy training block and you notice your hips bothering you, pull the pelvic wand out and use it the same way you would sit on a foam roller, right? So the same discussion of are we actually changing the muscle or are we like tuning down the nervous system? Same talk about that, but it's the same exact strategy, just internal muscles.
That makes way too much sense. Way too much sense. And it's so interesting that you bring up the concept of, hey, sometimes we have the best needling results by not needling the area that we're planning on. It's, again, going back into a concept I probably just undereducated call it muscular irradiation, or like this tension overflow, if you will, where essentially if you tense muscles in a certain area, it carries over into the muscles around them. And my go-to example is to have people make a white knuckle fist. And even though you're just squeezing your fingers at the hand, you'll feel tension build all the way up your arm into your biceps and sometimes even higher. So sometimes down-regulating stuff in one region actually has an effect so far elsewhere. And, we might not fully understand, or at least I don't fully understand it, but if it works, that's what we're after at the end of the day. And in the pelvic region in particular, I know there's a lot of different fascial layers here and tissue layers here as well. And this whole concept of fascia training comes up quite a bit lately. I'm interested, do you feel like fascial training or fascial contributions in the pelvic region matter? Are we changing anything? Are we training fascia here? Or is that just, hey, it's there anatomically, but it really has no impact on the performance and the function?
Fascia is so interesting. And it's like, any other topic, I feel like in our field, it can be super polarizing. And I've found that, now being in this field for almost 10 years, that like anything that's super polarizing, the real answer is probably somewhere in the middle.
Right.
So like yeah, you've got a camp that says fascia has nothing to do with anything. It is what it is. You can't train it, leave it alone. And then you've got a camp who's like, no, fascia is everything. If you don't treat the fascia, you might as well not treat at all. And the reality is, again, I fall somewhere in the middle, right? Like fascia is a component. It does affect, to me, from what I see clinically, how your muscles can kind of move on each other, how you get subjective feedback on what you're actually feeling. I think if all that is kind of stuck together, again, kind of what you were just talking on, a lot of my clients will like tuck their butt, like they clench the butt cheeks. And when they clench the butt cheeks, they clench the pelvic floor. When they clench the pelvic floor, all of that starts to almost like stick together. So when we start doing some manual work, do I think I am actually manually going in there and separating things? No. But what I am doing is changing your nervous system and changing how your nervous system perceives this input. And by doing that, can it let go a little bit? And when it lets go, can things slide and glide a little bit better, which means more fascial, mobility, which means better like fluid mobility throughout the muscle and things like that. Yes. So it's the same thing about like barefoot shoes, right? There's barefoot shoes for a while, and then it turned into like we all need the max stability super shoes, when the real answer is probably somewhere in the middle. Same thing with fascia. The pelvis, I think, is just going to be more vulnerable to that topic because of how many layers there are there, but it's the same, again, concept. It's just going to depend on what side of the spectrum you fall on. But clinically, I feel like I see good results with it. Now, does the research support that? Not exactly. But we published that postpartum athlete protocol in 2022. And it's so interesting because when we were doing peer review, when you do peer review, you get the article back and they say, hey, we don't like this, or where did you get this information from? Or they would circle something and be like, can you cite this? And I would have to respond and be like, I can't. There's nothing to cite. Like the pelvis in general, there is not a lot of research on it. So like the stuff that I'm putting in this article is just stuff that I've seen clinically, and you just have to roll with me on that. And if a research study comes out in 15 years that shows the opposite, I'm happy to rescind, right? I'm happy to say like, listen, we just didn't know enough at the time and we did the best what we could with the information that we had. But I think the fascial kind of mobility and the fascial approach is on the same level of like, there's definitely a component that you can tell clients leave and they're like, I feel better. I have more sensation there. I can tell what's happening. Do we know exactly why? No. But is it safe? Is it effective? Yes. So it's our job as professionals and providers to bridge that gap between here's the research, here's what I see in front of me, what happens here, right in the middle. And I think that's kind of where the fascial discussion falls.
It makes a lot of sense. And I feel like that's true about a lot of things in the space is you find people existing on polar opposite ends of the continuum. And a lot of the time, the real answer exists in the middle. And sometimes I'll lean closer to one side and sometimes I lean closer to the other. It's always a spectrum. And some days I'm sliding further to the left and some days I'm sliding further to the right. That's just how it seems to go in this space, if you will. And I realize that this is a conversation that could go on for hours and hours because we're literally just scratching the surface, right? You just brought up the postpartum athlete, for example, and there is a whole topic that could be had around the postpartum athlete. And once again, dumb young Dan thought that would never happen, that would never walk into his clinic. And then I open Facebook and see someone that I knew from my hometown at age 20 having a kid. And I'm like, wait a second. There's college kids that I work with that are 20, 21, 22. It can happen. It's just a matter of, are you prepared to help the athlete that comes in with that situation? And at least for myself, I know I've got a lot to learn. And it's one of those things that I think the more we talk about this stuff, the more we understand it, the more equipped we become as providers. As you mentioned before, the more confident we're going to be when we do work with athletes in person so that we're able to actually have a positive impact, intervene accordingly, and if nothing else, at least get them to someone who can steer the ship the rest of the way for them that way. Do you have any other kind of closing thoughts and closing remarks about pelvic floor function or dysfunction in the athletic population that way?
I think just from the perspective of, what you're saying here and your listeners in general, like, again, if you're listening to this and you think, gosh, I'm not really interested in pelvic health, I get it. I worked in sports and orthopedics for the first, 2-3 years. And then I had a kid and was blown away about how little I knew about my own body. But not only that, how little anyone could tell me about it. Like no one knew what to do, right? No one knew how to train in pregnancy. No one knew how to return to activity afterwards. And again, when that happens to you, you start to realize like, hey, that, 45-year-old female that just came into your clinic, no, she's not, quote, pelvic health, but she's had chronic back pain that started with childbirth, right? And she wants to run the Boston Marathon. So now what, right? That is a pelvic health case. And we have looked at it for so long as like, oh, that's purely low back. That's purely orthopedics. That doesn't have anything to do with pelvic health. And it absolutely does. So I really think that physical therapy in general, we've done a disservice to people by pretending that pelvic health is a specialty field. Now, is there nuance beyond the basics? Of course. Again, just like we have hand therapists, right? But we all should have some basic understanding, regardless of gender or regardless of what specialty we want to focus on, so that we can screen those out. Because I can tell you the people who end up in my clinic from their PT, when a PT says, you know what, this is a pelvic problem and I don't know how to help you, those people are so grateful to their ortho PTs to say like, thank you so much for acknowledging not trying to know everything, right? Because that's what makes you a good clinician, is to say, I don't know the answer to that, but I can find you someone who does, and I'm going to be on your team while we figure it out, right? So I'm going to send you here. I'll check in a couple weeks. And when they come into my office, they're so grateful that their PT said, you know what? I don't know. But if you don't know, like you said, you don't know, right? So you just keep treating low back pain, hoping it'll go away. And when it doesn't, you say, well, they failed traditional PT. And you have to have that awareness of, wait, there's something else. And so until we start educating PTs in general on that, we're going to continue to miss the mark.
Not being afraid to ask the question about there possibly being something else. Because obviously, if you never ask the question, you're just going to sit there and guess, well, maybe it is, but maybe it's not. It's always having that ability to assess. So I completely echo your points and love your wide array of knowledge and skill set and insights that you have that way. It certainly seems like you do a little bit of everything there. I don't know how you balance all the things, from recreational athlete to mom of 2 kids to business owner and entrepreneur to successful clinician to coach. I mean, you wear many different hats that way, Rachel. For people who want to find out more about you and the team at Synthesis, where can they find you all at?
So you can find me on Instagram at dr.rachelselman. That is where I put kind of most of my information. I try, Instagram's such a finicky beast, so I'm still learning. We're getting there, but definitely not like, a full-blown Instagrammer. But try my best and try to fight the misinformation that I feel is really present on Instagram right now, because you really have a hard time knowing who to trust. And especially for this, like, people will grift, right? Same thing's happening with perimenopause, menopause, like, buy these gummies, do this, supplement. And it's like, there are so many other discussions that we could be having. So I try to stay, relatively up to date on Instagram. We do have a Facebook page for Synthesis, but I'm going to be honest, I don't keep up with it very well. So Instagram's probably the place to go.
That's awesome. We'll link to that in the description below. That way, if you didn't quite catch it, you can just click there and see everything Rachel and her team are up to. Rachel, this is amazing. I really appreciate your time. Thank you so much for everything.
Thank you.